The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, and welcome to another edition of our Secrets of the USMLE series. This one is going to focus on tips for IMGs. We've heard from a lot of IMGs and FMGs who are kind of looking for a session kind of dedicated to their needs. So we thought that this would be the perfect time to address that and kind of give you guys a forum in which you can learn from a successful former IMG and learn some tips and tricks along the way. So again, I'm Jeff Downing, and what I'm going to do is I'm going to turn it over to tonight's special guest, and it's Dr. Richard Blumengold. So, Richard, I will let you take it away.
Thanks so much, Jeff. Good evening, everybody. Like Jeff said, my name is Dr. Richard Blumengold. I am an internal medicine resident at HCA Westside. I'm also an RX coach, working with students like you guys. And before I was a resident, I went to the University of Medicine and Health Sciences over in the Caribbean in St. Kitts and Nevis. So I have gone through the journey of the IMG. And the point of this presentation tonight is really just to give you guys some pointers, whether you're an M1 just starting out or an M3, M4 getting ready to apply, to get you ready. So tonight we're going to go through things like formulating study schedules for the actual steps, how we should approach questions, ways that you can dissect questions to make them a little easier, some expectations that I've found over the course of my time being an IMG between step 1 and step 2, as well as for our audiences in the 3rd and 4th year med school, tips for being on rotations and how you can stand out. The first thing we'll talk about here as we move beyond the poll is we're going to talk about how we formulate an actual study schedule. Now, I deal with students and have been dealing with students studying for their exams for a number of years now, and the biggest thing people talk to me about is, Dr. Blumengold, I don't know how to really formulate a schedule. I don't know how to stick to it. So what we're going to go through is a few tips that are on the next slide. So one of the things people lose track of is if you can establish a study schedule and stick with it, you're going to have far more success than someone who says, I'm going to study 12 hours today, 12 hours the next day. You need to set realistic expectations for your study. Consistency produces way more results than studying 10, 12 hours one day and then being too tired to do anything the next. In addition, most of IMG programs get presented material a lot faster than our US counterparts. My school in particular, we do our basic sciences in a year and 4 months as opposed to the traditional 2 years. And we're still expected to prepare and take the USMLE Step 1 at the same time as our US counterparts. So time management is going to be one of the biggest keys for any IMG. Now, the way we keep things fresh and make sure we don't get into the fog and the bogged down mentality is we alternate our study methods using things like first aid, using videos, using Anki cards, whatever serves you and whatever learning style that you have, you need to mix things in. This doesn't mean purchase every single manual on the USMLE that's available, but it does mean that you should have some type of variance between questions, book material, videos, flashcards when you get a moment. It's all about maintaining and being able to go 6 to 7 days a week. I always make my students take 1 day off a week to keep themselves mentally grounded through the process. On the next slide, we're gonna move forward, and one of the things that we really stress with scheduling in general, save the crammable subjects for the end. Everybody knows, everybody's gone through their studies, and things like biostats, we all know those formulas are a drag. Biochemistry, remembering those enzyme pathways, genetics, those are real memorization subjects, and you should really try and hold those off until the very end of your studies so that they're nice and fresh right before the exam. In general, if you can master the big three, pathology, pharmacology, and physiology, you're going to have a good basis and a good foundation to answer any question. We've all done practice questions, and we've all seen that most questions are not just biochemistry or genetics or just on cardiology. They're multifactorial. But being able to know the pathology, pharmacology, and physiology of each organ system for step 1, for example, and for our step 2 students tuning in, being able to understand the treatment modalities and the diagnostic steps will serve you really well. I preach to all of my students, staying relaxed and grounded is one of the biggest keys to success when preparing for the step. I've gone through the process myself. I've taken countless students through it. You need to find time for your hobbies, for things that bring you peace and happiness, because if you're preparing 2 to 3 months out, or you're an IMG that is just getting off of basic sciences and it has a very condensed time period to learn everything, it is going to feel very overwhelming if you don't give yourself time to take breaks, to go do yoga, to go meet with friends, to take your dog to the park. Whatever brings you joy, you need to maintain that. Do not put off life for this test. Make sure that the things that bring you joy are still a part of your life. As we keep going, one of the next things that we're going to talk on the next slide is going to be, as it changes forward, your day should realistically consist of about 60 to 120 questions a day, depending on how close you are to the exam. Now, if you're 3 to 4 months out of the exam, please don't try and do 120 questions a day and expect that you're going to be able to last on that schedule all the way through. When I develop study schedules for my students, when I first get them, they start at 60 and they slowly build up to that 120. Where they're reviewing, they're seeing the material every day, and we're trying to make sure we don't get to that place of, I'm still studying for the USMLE. All questions you do should be reviewed in a timely manner after you do the blocks. Now, whether you're doing questions on tutor mode, where you can review right afterwards, or you're doing time sets, where you're doing 30 to 40 questions at a time and reviewing afterwards. The idea is you should be looking at this material, seeing where you went wrong so that you cannot make those mistakes again. And when you're doing this, write down topics that you keep seeing that you're not quite getting. If antiarrhythmics are something that you've seen 3 to 4 times, you're getting questions wrong, write that down on a piece of paper. And then the next time you go into your book review, your topic reviews, make that a priority. That way you're staying organized, concise, and moving yourself to a place of understanding with weak areas. It is a lot of material, whether it's step 1 or step 2. You are expected to know a lot at any given time. You need to take a systematic approach and an organized approach to make sure that you can assimilate all of this information and be able to answer the questions. This will lead us into the next topic we'll talk about, where we talk about how it is that we should be going about and approaching our questions. Now, this is a 6-step modality that we at USMLE-Rx use, as well as that I've seen with all of my international students, always works. There's a few tips and tricks that we'll talk about later on, but for now, let's go on to the first step. When we have a consistent, organized approach to clinical vignettes, this is how we will maximize our score. During the test, it's extremely, extremely taxing doing, for step 1, 280 questions, and for step 2, 320. Most IMG programs, my program specifically, our block exams or the periodic exams for our subjects were between 100 to 150 questions. This pales in comparison to the 280 or 320 that you'll see on the USMLE. So given those numbers, time management and energy efficiency is what's going to bring you through to the end of the exam on a positive note. So the first thing that we like to do when we get questions is we want to, as we go to the next slide, will cover up or will at least ignore, if possible, the answer choices. The goal of this as a young doctor is for you to read the questions without any kind of bias and get yourself to a place where you know, or in your mind, what you think the correct answer is, and then match that with the most closely related choice. Doing this will allow you not to go into the question with any kind of preconceived notions or I think I know where this question is going, and it'll allow you to answer unbiased and strictly from the information provided for you, okay? Once you do this, you'll move on to our second step. In the second step, you're going to read the last sentence first. Now, the last sentence is going to be the actual question itself, the prompt, where they're going to give you what is the next most likely step, or what is the next step in diagnosis, or what is the enzyme that's deficient. Now, if you read this first before going through the entirety of the vignette, you'll now have an idea as to what the question is looking for rather than reading blindly. Because I see it time and time again when students don't do this, they'll read the vignette, get to the actual question prompt, and then have to go back into the STEM and reread. Please keep in mind, you only really have about 1 minute and 10 seconds to maybe 1 minute and 20 per question for each of the blocks that you take the USMLE. So you really don't have time to read an 8 or 9 line prompt, go and look at the question, and then go back through it again and have time to think through your answer. So like I said, time management is key. Once we read the last sentence, we move on to our step 3. In step 3, you're going to ask yourself, how many steps does this question require? Is this a simple question that's looking for what is the enzyme that's deficient in this particular problem? What is the genetic mutation? Or am I supposed to figure out the disease process based on what I'm given and then answer a question like, what in this patient's history was the most likely risk factor? Or what is this patient most likely to develop if the disease goes untreated? This will give you an idea that as you formulate, it may be very obvious in the first couple lines of the question, this patient has lupus, for example. Well, lupus can carry a number of different sequelae. What are they looking for specifically from me as the test taker? Once you have all 3 of these ideas, it's time for step 4, where you are going to turn around and read the actual vignette itself. This is where we navigate the vignette, the labs, and imaging. Read each sentence carefully. Don't just skim. Highlight and make note of what's important. One of the biggest pitfalls I see from students is we highlight everything. We think everything is important, especially our first and second years. We think everything is relevant. Our third and fourth years for the step 2 questions, the vignettes are long, and we want to make sure we have everything we think is important highlight. The point of highlighting is for you to have the most important information visually stand out to you that you can refer to quickly when you're trying to get to your answer. On this step, you will encounter multimedia type questions that are pretty common, where it may be a patient that's displaying a certain symptom, a video of them, or you may have to move a stethoscope around on a patient's chest and auscultate for murmurs. Okay, don't panic when you see them, but take the time to read the vignette first and get an idea of what they are looking for from you. For lab values, for IMGs, we really don't get instruction on what a normal lab value sometimes is. Schools differ. I know from my personal experiences, they basically directed us to say that the step 1 software has all of the normal values. You don't need to memorize it. But from my test taking, I saved a lot of time getting an idea of what the normal ranges should be. That way, I saved time from clicking on the lab value, scrolling through, trying to find this particular lab value, looking at the ranges, and then having to go back into the question after being distracted from my thought process. Once you have all your pertinent information assimilated, or at least highlighted, we move on to step 5, where we can call this assimilation or integration. We are taking all of our clues, everything that we just got from this question, and we are going to put it all together. Reread the last sentence. Now that I know who my patient is, always try to formulate your own diagnosis and then make the decision. Make the diagnosis. As a doctor, it's going to be your job one day when you guys are residents and you guys are physicians and attendings on your own. You will be tasked with making the diagnosis. Do not let the answer choice diagnose for you. If you're going through a question and you think the patient has, for example, diabetic neuropathy, okay? Look for the answer choice that may be worded in such a fashion that it corresponds to that. Get your own diagnosis first, then choose your answer based on that. And finally, we come to step 6, where we read the answer choices, starting with the last one first. I always stress this. If we start from the top and work down, we may encounter an answer choice that looks really, really good. It may be something we were thinking, or it may be our second option. Well, if we start from the top and work down, you may come across something that's not going to make you read the other answer choices. And I know for our step 2 audience, where we have questions that are, what is the next best step in management or the next best diagnostic step? Those questions rely on you knowing what is the order of diagnosis. What do I do first? I get an X-ray, then I get a CT. Whatever that may be, if you reach your first thing that you remember from your diagnostic thought process, you're not going to read the other answer choices. The second point here in step 6, cross out all answer choices that are incorrect or ones that you can eliminate. The step has a feature for you to X them out or line them out, and this will eliminate them from your visual field. Now, the final point from this slide, if you are stuck between 2 answers, always think which would occur first. If it's an enzyme deficiency, is the patient going to supersaturate with a particular solute and then the disease process occurs? Your job here for our step 2s, do we want to do a non-invasive study before doing invasive? These things will help you separate the answer choices. So this is pretty much our 6-step way to go about things. From here, now that we gave you our basic outline of approaches, we're going to move into our next topic of discussion, which is going to be dissecting tips, question dissection tips for IMGs. Now, all of the things I'm going to talk about are kind of just tips and tricks that no matter what level of the USMLE you are on, you can apply. Like I said in the beginning, our study schedules and content review as IMGs is very different from that of our US counterparts. So the focus is get all the information in your mind and then worry about the test taking later. What these tips come from is someone that was an IMG at one point and had success on the USMLE and learned these things from trial and error and in my experiences as a resident. When you are selecting and answer the first tip, use all available information. Do not try and take the proverbial square block and put it in the circle hole. Your job here is not to make your thought process fit the question. You're trying to make the question fit your thought process. Pay attention to things like demographics. If you look at the first line of any USMLE question, they start with a 40-year-old man, a 56-year-old female. If they go out of their way to give you things like ethnicity, place of birth, okay, these things are all relevant, especially when we talk about epidemiology. And for our step 2 audience, when they talk about a 40-year-old Caucasian female, they're going to have a very different diagnostic profile or things we will consider than, for example, a 70-year-old African-American male, okay? Timing is everything on these questions. In my example on the slide here, if you have a patient that comes in with acute chest pain, if they've had this chest pain ongoing for 3 days, there's really low probability that this is a myocardial infarction. Something else is going on here. However, if you have acute onset of shortness of breath, okay, I really don't think that acute onset of shortness of breath will be something like influenza, okay? Make sure one of the things you highlight in every question is the timing onset of symptoms. As an internal medicine resident, when I go to the ED and I'm triaging a patient to bring them into the hospital, I always ask, how long have the symptoms been present? Have they been getting worse? Have they been getting better? These things matter because they point us down a diagnostic pathway. Always, always, always make sure you look at the given list of medications and keep an eye for drug-drug interactions. I know I could speak for everyone here when doing USMLE questions. They like to, the patient has a history of coronary artery disease, diabetes, hypertension, and there's a slew of medications that they're taking. And somewhere in that list, there's 2 drugs, one of which may be a CYP450 inhibitor, one of which may be one that has a very narrow therapeutic index. So because one is on, the other will build up in concentration and cause the presentation, okay? Also look for things where if they're looking to add a drug, what is the contraindication? If a patient is already taking something like a PDE5 inhibitor, we can't give them sildenafil or Viagra, for example, because they'll get hypotension. These things all matter and will help you get to correct answers, particularly in the pharmacology sec. On the next slide, we'll continue with a couple of these dissection tips. When reading a question, look for outliers. The USMLE builds these questions very specifically to where they are saying everything that you need to ascertain your diagnosis, but they're not saying it explicitly. So if the question starts with, for example, a 48-year-old male from Southeast Asia or some other area of the world, it presents as an outlier because, as we know, not every question gives the ethnicity of our patients. So those outliers may indicate something. They may indicate lack of vaccination status. So we have to think about those things that in the US, for example, we may have eradicated with vaccinations, but due to differences in healthcare availability, they may still be susceptible. Exposure to different organisms, parasitic infections, and things that we really don't see in the US, for example, may be more prevalent where this patient has come from. Location of your patient is also extremely important. Pay attention to whether the question says the patient presents to the emergency department versus presents to the clinic. This gives you an idea as to, is this going to be an acute management situation? Do I have to do my A, B, C, D, E's, or can I slowly work this up and think about things? In the past couple of years, from what I've seen working with this test and working with students, contraindications and risk factors are becoming more and more prevalent in questions. For example, the one I give here, if you have a diabetic patient, one that you discover his A1C is greater than 6.5 and has overt diabetes, you have to check to see if this patient has a history of chronic kidney disease, because most common, one of the side effects of metformin is lactic acidosis, and patients with chronic kidney disease are at much higher risk. Questions will quietly tuck these things in and make sure that you have to really be reading and paying attention. When we move on from here, we're going to be discussing expectations for USMLE Step 1 and Step 2. Now, I get this question a lot. USMLE Step 1 just went pass-fail very recently due to COVID. As IMGs, this actually gives an opportunity for you to show your clinical prowess. Step 1 being pass-fail. In tradition, the USMLE is, for internationals, USMLE 1 is most of the time harder than USMLE 2, because as we go through clinical rotations, we have our courses in dealing with live patients and working through these simulated tests. For example, my school had SimLab that we did twice weekly. Even though the test is pass-fail for Step 1, you should be trying to gain as much proficiency with the material as possible. Just because it's pass-fail doesn't mean you do the bare minimum, because any effort you put towards Step 1 will pay huge dividends when you're preparing for Step 2. A solid foundation of clinical basics will allow you to understand the clinical management a lot better for Step 2. For our Step 1 specifically, try to learn all of our organ systems as a functional unit, as opposed to each one being an individual system. Meaning, for example, like I stated on the slide, when the kidney attempts to raise the blood pressure, the heart's going to respond by doing X, Y, and Z, which then causes the lungs to do this. you should be able to, in your practices and study, work through what each change, physiologically speaking, is going to do to the organ systems and how it is going to impact each other. The next slide is going to continue elaborating for our purposes on these expectations. And since we are doing this change, okay, step one, it used to be when I took the exam way back when, not to date myself, but you wanted to shoot for this very high score. We wanted between the 240 and 260, okay? My advice to all of you is don't make it about a number. Don't say I need a 260 or I won't get a residency, because you'll be taking practice exams throughout the time that you're preparing. So each time you take a practice exam, if you're not quite there, whether we acknowledge it or not, we're going to be frustrated with ourselves. You all are in medicine. This is a field of very competitive people. Whether we acknowledge it about ourselves or not, we expect success for ourselves and we want to be successful. We want to be the best of the best. So when we don't reach our goals, it can get frustrating, and this can lead to a drop in your energy levels and motivation to continue to strive. Aim to score high, don't aim for a score or a number, okay? This is going to be a mentality shift that is going to pay huge, huge dividends for all of you, and it'll make your study process a lot more peaceful mentally. The next thing that we're going to discuss, when the slide changes on, is going to be tips for IMGs on clinical rotations. So our M3s and M4s on clinical rotations, this is for you guys, and for our M1s and M2s, these are things for you to keep in mind as well. When you are on a clinical rotation, this is your opportunity to shine, okay? This is where you are going to make an impact, to make a statement. The clinical rotations are the great proving grounds where it doesn't matter what school you come from, this is your time to prove that you can be an asset to a program. Be there early and leave late. Don't stroll in 5 to 10 minutes before rounds and expect to get on a computer and review your patients that your residents assign and be able to perform in rounds. I have students with me all the time. They are in the hospital at the same time I am reviewing patients. We meet, discuss things, and the ones that always end up doing better are the ones that are constantly reading up on cases. If you're seeing a lot of strokes, for example, at the hospital you're at is the stroke center, read up on the clinical progression for strokes. And when the next time you get a patient, talk to your residents, say, oh, well, in my reading, we came across this should be the intervention we do. This is how we should go about it. This is the most acceptable, guideline. This will make you stand out. Be vocal on rounds and differentials. As a resident, I hate when students are wallflowers. We are physicians. We are capable of handling our patients. We want you guys to learn, and we want to see that you want to be there. We do not like wallflowers. We want students that are motivated, that are going to see the patients, that are sitting down and getting the full history, that are asking about what medications they took, how many surgeries have you had, has this ever happened before? Gathering good histories and being able to present them in an organized fashion to a resident, and more importantly, formulating your own treatment plans, what you think we should do. As a resident, I don't care if my students are getting every single aspect perfect. This is a learning ground. This is where you guys are going to start to learn what you're supposed to be doing when you eventually transition to a resident. We want to see you come up with novel ideas, okay? Don't wait for us to discuss with the attending to then say, oh, I was thinking of that as well. With regards to the shelf exam, prep for your shelves as though you are prepping for step 2. This was one of the biggest things that helped me succeed for step 2. Everybody looks at M3, M4 before they take their step 2 as I have so much time to prepare. Rotations go fast, and before you know it, you'll be in, if your school allows it, dedicated, or you'll have 4 weeks or need to be preparing for a step during one of your rotations. If you've been preparing the whole time, this will not be so stressful. If you haven't been doing that, it's going to be a very rough couple of weeks. If you look to score well and master each of the individual cores during your third year, when you sit for your step 2, or for our graduates that have already completed third and fourth year and are pending taking step 2, if you have done well through your shelves, it'll help you for your step 2 CK. In addition to these tips on this slide, the next slide is going to talk about, as IMGs, I hate to bring up the quote unquote stigma, but there is one that does exist around being an international graduate. This is unavoidable and something that we all, even myself, had to deal with when I was on the interview trail. Your school does not define the doctor that you will become. When you are preparing, when you are going to the hospital each day, when you are presenting to your residents, be dedicated, be deliberate, and remember why you started this in the first place. The name of the school on the left side of your white coat, your short coat, does not define what type of doctor you will become. Your work will. Consistency and curiosity will take you a long way. Ask questions. Talk to your residents. If you're in a rotation, specifically, if you're in a surgery rotation and you want to apply to surgery, you should be talking with those residents every day. Make every day count, every patient, every presentation on rounds, every opportunity to demonstrate to these residents, to this program, that you really want this. Because we notice, we know who the students are, for example, that may or may not want to be internal medicine. They may want family or pediatrics, and some of them kind of huddle to the back of the differentials when we're on rounds. They don't really talk much. We notice it. So make sure, if this is something you want, if this is a field that you want to be in, go the extra mile for it. And even if you are not inherently interested, you are still a professional. You are a doctor to be. You should be carrying yourself with a certain level of pride that your work matters to you. How you are perceived by your hospital that you're at matters to you. Nobody wants to have the reputation of lazy. On the next slide, we're going to, I believe there is going to be one more. Yes, this is one of the biggest hitters, and this goes for all levels that are on this call. Rotations are an excellent opportunity to network with residents and get yourselves working on research projects. Get involved in research early and actively search out opportunities. Everybody, when you're applying for the competitive specialties, every single person that makes it to the program director's desk in a file will have a high USMLE score. If you're applying anesthesia, surgery, orthopedics, dermatology, ophthalmology, every single person you're competing with will have a high score. Otherwise, they wouldn't apply in that field. How you separate yourself is with things like research, with publications, having your name in journals. Work with your residents. As a resident myself, I have academic requirements and publications that are necessary for my ACGME accreditation. So we are constantly working on projects and doing research. Talk to your residents, ask them, hey, Dr. So-and-so, I just wanted to know, is there any research you're working on that you may need someone to review data for or to organize things for? I'd love to get involved. Not only will this show that you're there for more than just to show up from 7 a.m. to 7 p.m., it'll show that you have a genuine interest in furthering your knowledge base. And always, if you take nothing else from our presentation tonight, always interact with hospital staff members as though you are speaking directly to a program director. This goes for nurses. This goes for patient care techs. This goes for attending physicians that you're not working with. You must present yourself as a professional, because you do not know who you are talking to, and more importantly, you don't know how much attention the program director gives that particular staff member. I have had people in my medical school that have fallen into this trap, and it's actually cost them opportunities in the hospital. So treat every staff member, every person you interact with, every patient you interact with dignity, respect, and be a professional when you step foot in the hospital.